Hello and welcome to this very brief overview on palliative care and end-of-life care. I just want to be mindful that this is quite obviously an emotive topic, although we're not really going to go into it in too much detail. It's just really to give you an overview and an understanding of what we mean by palliative care. But I am mindful that you may have experience of this or similar with a family member, so just be aware that it is an emotional topic. So what are we talking about when we are talking about palliative care? So have a wee think about what words come to mind when you think about it. What have you ever thought about palliative care? Is it something that's ever came into your mind? Is it a new concept to you, or do you have experience of it? Have you had a family member have to go through palliative care? And what are some of the words that you think about when you think about palliative care? Okay, so there are different definitions, but essentially palliative care should be an approach that is improving the quality of life of patients and their families who are facing, problems that are associated with life-limiting or life-threatening illnesses. So they do that by prevention and relief of pain and relief of symptoms. And essentially it's about early identification and assessments and treatment of pain and other problems. And it includes physical, psychological, psychosocial and spiritual support. So the World Health Organization includes all of those things in their definition of what palliative care should be. Really, when you break it down, you have to consider, well, what is palliative care? Essentially is, where do people want to die? Okay, is there really a best place to pass away, and do they have a choice? And that's about putting the control back onto the person who's living with the terminal illness. Some people would rather die at home if possible. Other people know that it's not possible for whatever reason for them to do that, so therefore they can choose where it is they want to pass away, who they want to be surrounded with. And really you can, I suppose, consider if there is a concept of what is a good death. Now this is really brutal language and it's quite hard for me even to speak about, but I suppose people are faced with these decisions every day. Families are faced with these decisions every day, and it's not something that can be avoided, unfortunately, for some people. So we really have to consider, well, what are the factors that contribute towards a good death. And really it's about being proactive instead of reactive. So it's about asking these questions. What do you want? What do you want when you're going to pass away? As I said, who do you want around you? Where do you want to be? Instead of it happening or happening suddenly, and then people have to sort of clamber to decide what the patient might have wanted. Okay, so it's about being proactive instead of reactive. Okay, so palliative care has been around for quite a long time. The first hospice solely for people who were dying was in France in 1842. And then there was the modern day hospice movement in the UK, and that really just recognised that there was unmet needs for those who were dying. So really, Dame Cicely Saunders realised that patients who were dying were not receiving the quality of treatment they deserved, and she essentially identified that patients, still deserved a good quality of life for the life that they had left. And she put in place the first she pioneered the first modern day hospice movement. And that was founded in St Christopher's in London in 1967. And then it took to 1987 for palliative medicine to actually be accepted as a speciality. So people do become palliative medicine doctors. And 1987 seems not that long ago, for me at least, but yeah, it took that long before it was recognised as its own speciality. So really there is a philosophy that is associated with palliative care, and it's back to that patient or person-centred care as opposed to being diseased focused. So who is the person and what matters to the person? what makes a person happy, what gives them joy, how can we meet their needs, how can we value their input. All of these things are about person-centered care, and it's about working with the person, working with the patient, working with their family, so that we can make their time as comfortable and as joyful as possible. And really that involves a holistic approach. And it's all about respecting the patient's needs, respecting their input, respecting that they know what's best for them. We can't tell people what's best for them, we can advise them, but essentially it's what makes the person happy, with what makes the person content, and it's what matters to the person is what we should be carrying out. Essentially, at the very core, palliative care is about comfort and dignity. So patients shouldn't be left to die, you know, in ways that are not dignified and not comfortable. Okay, so there are some principles of palliative care that help to achieve that comfort and dignity, and it's about providing relief from pain and distressing symptoms. So we talked last week, remember, about cordotomy and other interventional procedures that help to do that. So that would be a component of palliative care for patients with mesothelioma, and other interventional procedures as well, and other types of drugs and interventions to try and make sure that patients remain as pain-free and as symptom-free as possible. And it's about affirming life, okay? Dying is a normal process, as hard as it is for some people to cope with, which is obviously natural. But one of the principles of palliative care is affirming that the life that the patient has had up until this point, and making the remainder of their life as as dignified as possible. It's not about postponing death. It's not about hastening death. It's accepting that death is inevitable for this patient, and again, making it as comfortable as possible. And it's integrating the psychological and spiritual aspects of patient care. So some people may receive counselling, spiritual advisors. There is spiritual chaplains and people like that who will go into the hospice and ask if a patient would like any sort of spiritual care. And it's not always religious. Many of the chaplains or the spiritual advisors in the hospital, they're not there to preach, they're there to listen, they're there to support and help people with the process of dying and accepting death. Some of the other principles is the fact that you offer a support system. So you want patients to live as actively as possible until they do die. It's not about learning that you've got this terminal diagnosis and then that's just it. Many people will still be able to live in some ways actively up until they pass away, and palliative care is about supporting them to do that. And it's looking to the extended circle of family and friends and how we can support them through a patient's illness and then subsequently their own bereavement. And it's a team approach, so it's a multidisciplinary team approach. There'll be nurses and counsellors and doctors, lots of different people who play a part in the patient's team, and radiographers, because as we've said previously, interventional procedures are part of palliative care. So if you go into interventional radiography, you will be part of the palliative team, the wider palliative team, because you will be helping to alleviate, hopefully, patients' symptoms so that they're more comfortable. So, that's such an important role. So this is a wee quote about what a hospice is. So it's not just about dying, it is about quality of life. A lot of people think it's about the end, but it's far from it. And that was from a partner of a patient who was in a hospice. So that's the really important things to think about. It's not just a place where someone just goes to die and is left to die. It's about really letting them live out their final days the way that they want to, and trying to let them live as actively as possible. So there's different services offered within palliative care and in hospices. So symptom control, we've talked a lot about that, and radiographers do play a big role in that. There's obviously practical and financial advice. So illness unfortunately can have financial implications, and as much as you'd like to think that money shouldn't matter, it absolutely does. And people need advice about how they can leave money for their family or support their family up until the point it comes to them passing away or whatever it might be. There's also support for patients and carers who maybe have issues that are important to them and they want to talk through them, basically about what matters most to the family, that person-centred care again. There'll be patients who are really, really terrified about leaving their dogs. There'll be patients who are really terrified about leaving their children. Whatever matters to them the most, and they get an opportunity to talk through that with someone in the palliative service. And they have this holistic care approach, so it's about physical, emotional, social and spiritual, and about support for the wider circle of family and friends. So it's not just for cancer patients, although that is, the main focus that we've spoken about in this module. Obviously, patients who have chronic lung disease, neuromuscular disorders, dementia, heart failure, and lots of other terminal diagnosis. But we are talking about it in the context of cancer. And the people who can refer someone to the palliative service or to a hospice would be a GP or a hospital consultant, anyone who's involved in the appropriate management of the patient's care. The palliative care consultant or nurse can refer to a hospice as a direct referral. So it's important to note that in a hospice, it's not all about inpatient, although they do have inpatient units. They have inpatient units for end-of-life care and for symptom management, but they also have outpatient and day services as well. So patients who are terminally ill can come to the hospice or the palliative care centre and have symptom management, see their medical staff, but also have physiotherapy, occupational therapy, and also art therapy and maybe acupuncture and these complementary therapies as well. And they can see their support groups and peer support and support bubbles to help them through this really difficult time. So the hospice community really work alongside the GP, the district nurses and the consultants. Again, we've mentioned it before, but they are trying to support patients in their home as well as they can support patients in the hospice. When patients are at home, which a lot of patients prefer to be, the district nurses and doctors can help them with pain control, help them with financial advice, emotional and spiritual support. They can actually also bring in education as well, so maybe for children who or anyone who requires or would like some education support, they can organise that, and they can work in partnership with the hospitals and the cancer centres, and they're made up of lots of different members of the interdisciplinary team, so doctors, nurses, specialist staff. So we're coming towards the end. This is just a very, very brief overview of what palliative care is, but it's important to remember those people who are already providing this care in an unofficial capacity. So in the UK, there's about 6.5 million people who are giving care to friends or family unpaid, and that's predicted to rise to about 9 million by 2037. So you might even be a carer yourself. And it's important to recognise the contribution that unpaid carers are making. So in the UK, about 6,000 people a day take on new caring responsibilities, and that can really have an impact on the carers' relationships and their career and their finances and their health and well-being. And actually, without these unpaid carers, Scotland would have to find an extra 10 billion a year, which is the equivalent of another NHS. So if you are a carer, you're really doing such a wonderful job. And without carers, unpaid carers, we really would be struggling to financially support everyone. And it is calculated we'll be carers at some point in our life. So we never really know when we're going to find ourselves in that situation. And it can be temporary or it can be a bit more permanent as well. Okay, so if you ever do find yourself in that situation or you know anyone that does, hospice support is available and they can help to provide emotional support because being a carer can be very emotionally taxing. And they can also provide any pre or post bereavement counselling as well. There's nursing and medical advice, and then there's also all these complementary therapies and family art workshops that are available for carers as well as the patients themselves. And there's support groups available for carers too. So I have put some references here. I'll upload these slides just in slide form as well, if you ever want to look at any of the palliative care information. But thanks for listening to this short talk. It really just is to give you a very basic overview of what we mean by palliative care and what we mean by hospice end of life care. Thanks. See you at the tutorial.